Hello and welcome. On behalf of CME Outfitters, I would like to welcome and thank you for joining us for episode 2 of this 3-part CMEOCast podcast series titled Treatment and Sequencing Strategies Providing the Best Care for Patients with Metastatic Urothelial Carcinoma. The podcast series is supported by an educational grant from Pfizer Incorporated and EMD Serrano Incorporated. I'm Dr. Daniel Petrolak, Professor of Medicine and Urology at the Yale School of Medicine. I'm also co-director of the Signal Transduction Research Program at the Smilow Cancer Center in New Haven, Connecticut. I'm joined today by my friend and colleague, Dr. Guru Sampavdi. Dr. Sampavdi is the Bladder Cancer Director at the Dana-Farber Cancer Center and Associate Professor of Medicine at the Harvard Medical School in Boston, Massachusetts. Welcome, Guru.
Thanks, Dan.
In addition to CME/CE credit, today's activity is eligible for ABIM MOC points. Once you complete the activity, provide your ABIM ID and birth date when completing the evaluation. CME Outfitters will submit your MOC points. You can also claim this activity as a CME for MIPS improvement activity. Over the next 90 days, actively work to incorporate improvements in your practice presented in today's activity. CMEO will send you a follow-up survey in approximately 3 months. Upon completion of the survey, CME Outfitters will send you confirmation to submit your CMS attesting to your completion of a CME for the MIPS. In episode 1, we focused on maintenance treatment for patients with metastatic urothelial carcinoma. Our learning objective this episode is to utilize upfront treatment and sequencing strategies in metastatic urothelial immunotherapy to provide the best care with second-line treatment options. For systemic treatment of metastatic urothelial carcinoma, we have several lines of therapy. For first-line therapy, for those patients who are eligible to receive cisplatin, gemcitabine and cisplatin followed by avelumab is considered to be one standard of care. Dose-dense MVAC chemotherapy followed by avelumab maintenance therapy in those responding patients is also considered to be a standard of care. In cisplatin ineligible patients, we have gemcitabine carboplatin, which can be followed by avelumab maintenance, as well as pembrolizumab or atezolizumab in those patients who are PD-L1 positive. Second-line therapy can also include immune checkpoint inhibition for those patients who did not receive checkpoint inhibition as maintenance therapy, and also if a patient has FGFR alterations, erdafitinib can also be administered. Additionally, enfortumab vedotin is also approved as a third-line patient treatment for metastatic urothelial carcinoma. So we do need second-line therapies for localized and metastatic urothelial carcinoma, as we know that platinum-based chemotherapy is a standard of care for first-line treatment. We do see responses in about 40 to 50% of patients and disease control in 70 to 80% of patients, but the responses generally as just for chemotherapy alone are not durable, and most patients will have disease progression by about 9 months. So the clinical management is challenged by the heterogeneous patient populations and underscores the need to optimize second-line therapy and treatment strategies to yield durable responses. Pembrolizumab and atezolizumab are approved in the first line, but are restricted to those patients who are platinum ineligible, and we often will use chemotherapy in those patients who've progressed after initial checkpoint therapy. So I think it's important that we think about our definitions. So Guru, platinum eligibility has been a subject of many studies. What's the definition for a patient who is platinum ineligible? And is there a hard and fast rule?
Thanks, Dan. So platinum ineligible patients as opposed to cisplatin ineligible patients constitutes a somewhat unclear group of patients. So these are patients who are not eligible for either cisplatin or carboplatin-based chemotherapy. So these are the so-called platinum ineligible patients, which is a new third group of patients that was created along with the approvals of atezolizumab and pembrolizumab for this population. So Gupta and colleagues did a survey of oncologists to look at whether we could arrive at a consensus for this definition of this group of patients. And in this survey, they surveyed 43 responses in round 1, and they got 47 responses in round 2. So admittedly, not a very big sample size, But what this group recommended was if patients had one of the following, they could be defined as platinum ineligible. So this included an ECOG performance status of 3 or higher, creatinine clearance of less than 30 milliliter per minute, peripheral neuropathy grade 3 or higher, NYHA class 3 or higher heart failure, or a combination of ECOG PS2 and a creatinine clearance less than 30. So these were the criteria they came up with. This paper has still not been published, and it's been reported, though, at a major meeting. But again, this is just a consensus criteria, and this is not something scientifically established, of course. I think at this point, maybe I will ask you, Dan, to summarize the immune checkpoint inhibitors in metastatic urothelial carcinoma. Where are we at?
So basically, there are FDA-approved checkpoint inhibitors, and we have different levels of data that support their approval. Atezolizumab and pembrolizumab were the first two to be approved, and atezolizumab was based upon phase 1 and phase 2 data. It received accelerated approval based upon the phase 2 data, and there was a phase 3 trial, which Guru will go into more detail later, that evaluated atezolizumab versus chemotherapy. Pembrolizumab also had a phase 3 study. It was approved based upon phase 1 and phase 3 data, and I think the interesting thing about all these studies is that the level of PD-L1 expression seems to be very, very similar, but they seem to have similar rates of PD-L1 expression. Nonetheless, they have a similar response rates overall. The survivals seem to be very, very similar for all these agents. The real issue is you can't compare them because you have different studies, different levels of prior treatment, particularly in phase 1 studies. And so again, we have checkpoint inhibitors, only 2 of which are approved for frontline therapy. So Guru, what are some of the options for patients who are ineligible to receive cisplatin-based chemotherapy?
Right, thanks, Dan. So there are 2 agents approved in the first-line setting of cisplatin ineligible PD-L1 high expressing patients or platinum ineligible patients in the first-line setting. So the first one is pembrolizumab that I wanted to describe first. So pembrolizumab was looked at in the first-line setting in a large non-randomized phase 2 trial that led to its approval in this cisplatin ineligible setting. So this was a trial of 370 patients that had cisplatin ineligible patients. And the primary endpoint was overall objective response rate, with secondary endpoints of duration of response, progression-free survival, overall survival, and safety. And essentially, in this trial, this was a fairly large, although non-randomized trial of 370 patients. And the median survival was just short of a year, 11.3 months. And as you can see, the median PFS was brief in the 2.2 month range, but the response rate overall was around 28.5%. And so these data actually led to the approval of pembrolizumab in the first-line setting of all patients who were cisplatin ineligible. That was then changed, of course, based on the phase 3 data in the first-line setting. So this was the data with pembrolizumab that led to its approval, actually, and the toxicity profile was consistent with what we knew with pembrolizumab in terms of immune adverse events, grade 3 or grade 4 in approximately 20% of patients. And then the second drug approved in the first-line setting of cisplatin ineligible patients is atezolizumab, and this was also approved based on a non-randomized phase 2 trial, IMvigor 210, which had 110 patients in this cohort of cisplatin ineligible patients in the first-line setting. The primary endpoint was, again, objective response rate with other routine secondary endpoints. The trial allowed patients, regardless of PD-L1 status. In this trial, patients did not have as big a gradient of response rate based on the PD-L1 expression. So really, even based on this trial, atezolizumab was approved in the first-line setting of all cisplatin-eligible patients when it was first approved, which of course was later amended based on the phase 3 trial, which came out later based on the comparison of first-line atezolizumab with gemcitabine platinum in that phase 3 trial. When you look at the overall survival in this IMvigor210 phase 2 trial, the median survival was somewhat impressive, 15.9 months. Somewhat an outlier in my opinion, but this was still a non-randomized phase 2 trial, which showed this median survival of 15.9 months. And actually, the median survival was longer in the PD-L1 low, 0 or 1 plus patients, where it exceeded a year and a half. So really, PD-L1 did not seem to perform well in terms of association with survival in this atezolizumab first-line study. So going on to the switch maintenance space, Dan, you were involved in the Javelin Bladder 100 switch maintenance space. You want to explain to us what this trial is about?
Sure, Guru, thank you. So I'd like to talk about Javelin 100. What Javelin 100 did was take patients who had metastatic or unresectable locally advanced urothelial carcinoma. They received either cisplatin gemcitabine or carboplatin gemcitabine chemotherapy for 4 to 6 cycles. If they were responding, they were eligible to go on the switch maintenance, which meant that they received either avelumab at 10 milligrams per kilogram every Q2 weeks or best supportive care. And the patients were treated until progressive disease or unacceptable adverse events. The primary endpoints of the study were overall survival in all randomized patients, as well as the PD-L1 positive patients. Secondary endpoints included progression-free survival by RECIST version 1.1 and objective response rate by RECIST 1.1, as well as safety and tolerability and patient-related outcomes. So as we see in the first slide, when we look at all patients that were treated in the Javelin 100 study, the median survival of avelumab combined with best supportive care was 21.4 months versus 14.3 months for the best supportive care alone. The hazard ratio was 0.69. If we look at the PD-L1 positive patients, we have not yet achieved a median in those patients who received avelumab plus best supportive care, but it's 17.1 months for those patients who received best supportive care alone, and the hazard ratio is 0.56. So we're seeing really a significant difference in survival in those patients who receive switch maintenance therapy after platinum-based chemotherapy. So Guru, what about some of the other PD-L1 inhibitors? Let's start with nivolumab and the CheckMate 275 study.
Thanks, Dan. So nivolumab is a PD-1 inhibitor. This was approved on the basis of this non-randomized phase 2 trial conducted in patients who were progressing post-platinum-based chemotherapy. This is the CheckMate 275 trial that administered nivolumab 3 milligram per kilogram every 2 weeks in this trial. And this trial was a fairly large non-randomized phase 2 trial of 265 patients with a primary endpoint of objective response with other secondary endpoints of PFS and OS. And in this trial, the agent was active and essentially looked similar to the other PD-1 L1 inhibitors with an overall objective response rate of 19.6%. The median survival was 8.7 months. And really, when you look at the median survival across the PD-L1 high or low groups, there seemed to be some separation here. But again, this trial was not powered to look at the differences in outcomes based on PD-L1 expression. So based on these data, nivolumab was approved for progressive disease post-platinum-based chemotherapy. And when you look at the toxicity profile, the toxicity profile looked similar to other PD-1 L1 inhibitors, grade 3 or 4 treatment-related adverse events occurring in about 18% of patients.
So Guru, does what you choose first when sequencing matter as far as your subsequent therapy is concerned?
Thanks, Dan. So this is an important question. And this question really has not been answered definitively. However, one data set I wanted to highlight was this retrospective study we conducted of patients who got a PD-1 L1 inhibitor as first line, followed by carboplatin-based chemotherapy, or the reverse sequence of carboplatin-based chemotherapy followed by a PD-1 L1 inhibitor. And we picked carboplatin-based chemotherapy because you really wouldn't have a cisplatin-eligible population getting a first-line PD-1 L1 inhibitor. So we picked a population where it made sense to examine a somewhat well-selected cohort that received both the platinum-based chemotherapy and the PD-1 L1 inhibitor in some sequence. And this was not a large study. It was 146 patients of patients getting one of these two sequences. Suffice it to say that the outcomes overall looked similar. Survival was similar regardless of the sequence. Again, this is cisplatin ineligible patients. One of the interesting things we saw was the patients who got the first-line platinum-based chemotherapy, carboplatin-based chemotherapy, they tended to have a more of a gap between the first line and second line treatments. Remember, in this study, this is the pre-Javelin Bladder 100 era. So the second line treatment was triggered by progression and was not switch maintenance. And so really, so after platinum-based chemotherapy, there was a little bit more of a treatment-free interval. So that was interesting data when we looked at the sequencing retrospectively. So Dan, now we have trials that have been presented that have, in the first line setting, looked at large phase 3 trials that combine chemotherapy with a PD-1, PD-L1 inhibitor. Did you want to talk about the Keynote 361 trial?
Sure, thank you, Gauri. I'd be happy to do that. So, the hypothesis here was, does adding your best agents, does adding chemotherapy to checkpoint inhibition therapy give you a better overall outcome than chemotherapy alone? So this was the question that was asked with Keynote 361, Pembro plus chemo versus chemo alone for first-line patients with metastatic urothelial carcinoma. Again, these are patients with locally advanced or metastatic urothelial carcinoma. They could not have prior systemic therapy for metastatic disease. They had to have an ECOG performance status of at least 2 and tissue available for PD-L1. They were stratified based upon PD-L1 expression as well as the choice of the platinum-based compound that was used, either cis or carbo. And this was a 1-to-1 randomization between Pembro plus Gem-Cis versus Pembro versus Gem-Cis alone. The dual primary endpoints were progression-free survival, as well as overall survival, and secondary endpoints included objective response rate, disease control rate, and duration of response by RECIST. So this is somewhat disappointing. These are the survival curves, both for PFS and OS for the study. As we see on the left, the PFS event rate was 71.4% with the combination therapy. For chemotherapy alone, it's 66.2%. So it's about a 1.2 month difference at the median. Pretty disappointing overall. At 12 months, 33% versus 29.9% of patients were progression free. So this did not meet the significance level necessary for being a positive study. If we look at overall survival, again, disappointing. The hazard ratio is 0.86 when you compare chemotherapy to Pembro plus chemotherapy. If we look at the IMvigor130 study, this was a 3-arm trial that looked at atezolizumab combined with platinum gemcitabine compared to atezolizumab monotherapy, compared to placebo combined with platinum plus gemcitabine. Again, metastatic or locally advanced urothelial carcinoma. There were co-primary endpoints, which included investigator-assessed RECIST, PFS, and overall survival. And then the secondary endpoints included investigator-assessed confirmed response rate, duration of response, progression-free survival, overall survival, and safety. Again, we see a very, very similar pattern with the IMvigor130 study to what we saw with the pembrolizumab trial. The hazard ratio for progression-free survival was 0.82. And the same thing was seen with overall survival. Stratified hazard ratio for death was 0.83. So that was not considered to be significant. If we look at the atezolizumab monotherapy versus placebo plus platinum-based chemotherapy, we do start seeing some separation in the curves. Again, the stratified hazard ratio for death was 0.68.
So Dan, you want to tell us about switching gears and going to a different drug, erdafitinib, the first targeted agent approved in this disease?
So it's really great to see that we are beginning to have more options for our patients. And using the molecular approach towards treating patients or targeted therapy is now coming into vogue for urothelial carcinoma. So about 20% of patients with advanced urothelial carcinoma will express mutations in the FGFR receptor. And there's an FDA-approved agent for locally advanced or metastatic urothelial carcinoma with FGFR3 alterations who have failed platinum-based chemotherapy. And this is erdafitinib. It's administered 8 milligrams orally once a day, and you increase the dose based upon the tolerability to 9 milligrams. The response rate's about 40%, 3% CRs with 37% PRs, and the median progression-free survival is about 5.5 months. There are treatment-related adverse events, and these need to be monitored carefully because you can either dose reduce or give the patient a break to potentially avoid these. So these include hyperphosphatemia, stomatitis, dry mouth, diarrhea, dysgenesia, dry skin, alopecia, decreased appetite, hand-foot syndrome, as well as fatigue and nail discoloration. Ocular toxicity also can come into play, and patients do need retinal exams to be sure that they're not having any retinal issues, which may be a result of erdafitinib treatment. Another drug that does have significant activity in metastatic urothelial carcinoma is enfortumab vedotin. This is a smart bomb. So enfortumab is a antibody drug complex or conjugate, and this conjugate recognizes a protein called nectin, which is expressed in practically all urothelial carcinoma specimens. It then delivers an antitubulin agent, MMAE, to the cancer cell with very, very specific targeting of urothelial carcinoma. So basically, you can get higher doses of these taxane-directed therapies, or excuse me, tubulin-directed therapies to the cancer cells than you would normally. So the EV201 trial was a phase 2 study that looked at RECIST criteria as the primary objective by blinded independent review. The secondary endpoints were duration of response, progression-free survival, and these were patients who were treated previously with chemotherapy and with anti-PD-1 therapy, and they had to have performance status of 1 or better, and they could have no limit on the prior lines of therapy, including taxanes. Again, enfortumab vedotin was given at 1.5 milligrams per kilogram on days 1, 8, and 15 of a 21-day cycle. And we see that the response criteria for accelerated approval was met, with 44% of patients having a objective response, a 12% complete response rate. And again, this is in patients with multiple lines of therapy. It's important to note that there's a phase 3 trial which is compared enfortumab vedotin to dealer's choice chemotherapy, either vinflunine or docetaxel. And this is a phase 3 trial, which was in press release form, has met its primary endpoint. So we'll see more data in the future as that comes forth. There are other agents that are in development for metastatic urothelial carcinoma, and these include sacituzumab govitecan. This is another antibody drug conjugate, except that we're using a different target, which is TROP2, as well as a different payload, which is SN38. So in theory, these should not be cross-resistant with either FGFR3 inhibitors or either with enfortumab vedotin. So we have other options for these patients, and hopefully we'll see approval of this drug within the next year. Another combination that's being evaluated is anti-VEGF therapy with PD-L1, particularly lenvatinib combined with pembrolizumab. So these are patients who can be fragile, and we need to manage their side effects very, very carefully. Guru, adverse events are parts of therapy. What are the general principles that we can use to guide us in managing these adverse events?
Right. Thanks, Dan. So the immune adverse events have been somewhat of a learning curve for us medical oncologists. So these are not predictable and occur at a specific time, which we were used to for a long time with chemotherapy, with the reversible transient myelosuppression. So immune-related adverse events can occur over a long period of time, and even after you stop the immune checkpoint inhibitor. So we need to educate patients and families about toxicities throughout their treatment and survivorship. We need to maintain a high suspicion that new symptoms could be treatment related. Any new symptom, tell your patients not to self-medicate for diarrhea or cough. They need to let us know if they've had an immune checkpoint inhibitor, if they have any new symptom. Consult with a relevant specialist promptly, and that could include dermatology for a skin rash, gastroenterology, pulmonary medicine, endocrine complications can be seen, as we know, with pituitary, as well as adrenal and thyroid hyperfunction. If there are toxicities which are felt to be from immune checkpoint inhibitors, we have to hold the drug and wait until the toxicities revert back to grade 1 or less. But a lot of this depends on the severity of toxicity. We may not want to re-challenge these patients, especially if they have severe toxicities. So how do we manage these toxicities? We look at the grade of these toxicities. For a grade 1 immune-mediated adverse event, we could potentially just closely monitor patients. We could continue the agent. We don't necessarily have to stop the agent. Now, for grade 2 events, you would need to hold the immune checkpoint inhibitor and potentially resume if the symptoms revert to grade 1 or less. Steroids, corticosteroids, may or may not be necessary for a grade 2 event. Grade 3 event, now that's a severe event. Hold the immune checkpoint inhibitor, and this is a grade at which you would need to start corticosteroids at 1 to 2 milligram per kilo per day, and also taper steroids over a course of 4 to 6 weeks. Remember that some toxic events would need intravenous steroids and may not be controlled with oral steroids, especially gastroenteritis, colitis, in which case an oral steroid may not be well absorbed. If symptoms do not improve within 48 to 72 hours, so that's a pretty short time span. If you don't see a prompt improvement in 2 to 3 days, you might want to consider infliximab, which is a TNF alpha antagonist in this situation. If a patient has a grade 4 event, you need to permanently discontinue the immune checkpoint inhibitor, and you would need to start probably 2 milligrams per kilo per day of methylprednisolone, a higher dose. And unless it is an endocrinopathy, you would not want to resume the immune checkpoint inhibitor. So Dan, you want to tell us what the NCCN guidelines tell us about second-line systemic therapy options and options post-checkpoint inhibitor?
The preferred regimen for cisplatin ineligible chemotherapy naive treat patients is gemcitabine and carboplatin. Other recommended regimens can include erdafitinib, paclitaxel, docetaxel, gemcitabine. Alternative preferred regimens for cisplatin eligible chemotherapy naive patients include gemcitabine cisplatin, as well as dose-dense growth MVAC with growth factor support. In circumstances based upon their prior medical therapy, we can go with ifosfamide doxorubicin, as well as gemcitabine and paclitaxel. So again, we have a variety of different agents and different ways of sequencing these agents. Guru, thank you for your insights into your practice. Let's summarize our discussion with our SMART goals: specific, measurable, attainable, relevant, and timely. That is what I hope that our audience will take from this presentation to apply to their practice. Evaluate efficacy data for second-line immune checkpoint inhibitors in patients with metastatic urothelial carcinoma, utilize upfront treatment and sequencing strategies in metastatic urothelial carcinoma immunotherapy to provide the best care with second-line treatment options, integrate strategies for the management of adverse events, inclusive of the multidisciplinary healthcare team based on grade of treatment-related toxicity. As mentioned in the open, this activity is the first in a three-part series. If you haven't already participated in episode 1, we hope that you will, and also check out episode 3 of the podcast series. These activities are free resources, and education for both healthcare providers and patients are available on CME Outfitters Oncology Hub. To collect your credit for today's activity, you can click on the link to complete the evaluation. You will be able to print your certificate from the platform. As a reminder, if you'd like to apply for ABIM MOC credit, provide your ABIM ID and birth date when completing the evaluation. CME Outfitters will submit your MOC points. Thank you, Guru, and thank you all today in the audience for joining us.